Good morning. Thank you all for coming and for coming back from the small break. We are here for session WEAC01, PrEP Expectations and Experiences. I'm Jared Baton from the University of Washington, and I'm so happy that this session is here in the big room talking about this topic and with 6 young people, including 4 women. This is a good session to be having. And while there's lots of great things to talk about science and PrEP, the implementation and what it's meaningful for people and patients in the world is actually more important and interesting these days. So this is great to have this session. I'm here with my co-chair, who will introduce himself, and then we'll start.
Good morning, everyone. I'm Dr. Camille Anoma. I am a director of a local NGO in Côte d'Ivoire, Espace Confiance. We just have to start with our first speaker, Adeline Bernier from France. She is a member of the community research programs of Coalition Plus. Welcome, Adeline.
Here we are. Okay, well, good morning, everyone. As Camille just said, my name is Adeline Bernier, and I'm working in the community-based research program in Coalition Plus, which is an international network of community-based organizations across the world. So today I'm going to speak on behalf of many, many partners, and I will present the barriers to uptake of PrEP among respondents to the Flash PrEP in Europe survey. And I don't have any conflicts of interest to declare. So here's the outline of my presentation, a little bit of context, the methodology, some results of the survey, including the PrEP cascade, and the barriers, and some conclusion. So as you all know, PrEP is effective in preventing HIV infection among at-risk groups. In 2015, WHO extended recommendation of PrEP to all populations most exposed to HIV infection. And they've actually just released, during this conference, an implementation tool, in which the criteria are even broader. And regarding Europe, in 2016, the European Medicines Agency authorized Truvada to be used as PrEP in Europe. And as of summer 2016, France was the only European country to provide and fully reimburse Truvada for PrEP. So in this context, we launched the Flash PrEP in Europe survey. So the objective was to better understand knowledge, interest to take, and current use of PrEP in Europe. And we used a community-based research approach involving 17 NGOs across 12 European countries and 2 universities. It was available online last summer, and it was directed at a larger population than just MSM. So here are some results. We had more than 15,000 respondents from all over Europe. You can see the numbers on the map. So 92% of them were males, 6% were females, and 2% were transgenders. And among the males, 70% of them were coming from Germany. So this is due to the recruitment method. I won't have time to go into details, but what you need to keep in mind is that for the rest of the presentation, I'll present the results for 4 different groups: German men, other European men, women, and transgender. So here you can find some characteristics in the top part of the table. So we won't go through the whole table, but I just wanted to highlight some things. So regarding men, the great majority of them declared having had sex with men in the last 6 months. So basically, we reached MSM. Regarding women, 81% of them declared having a main-sex partner. So we reached, most of the women we reached were in a stable relationship. And regarding trans people, they were a little bit younger than the other groups, and they had a less comfortable financial situation. Now, getting to PrEP knowledge, so it was PrEP knowledge prior to the survey. So what you can see here is that the results are highly variable for the different groups, ranging between 37% for German men, I don't know if I can, yes, 37% here for German men, to 77% for other European men. And in terms of PrEP interest, it was also highly variable between the groups, going from 18% for women here to 54% for other men. Now, we wanted to look more into gaps and barriers. So to study the gaps, we did the PrEP cascades. So how did we do that? In our sample, we selected people at risk. So we used existing guidelines from CDC or EACS based on sexual partners, condom use, STIs, injecting drug use. As associations, we don't really agree with this criteria, but here that was just a way to select at-risk respondents in our sample. So that's the 100% bar on the left. So from those 100% bar on the left of the respondents at risk, 55% of them knew PrEP before the survey. Among those ones, 73% of them were interested in taking PrEP. And among those ones, 19% of them had already taken PrEP. So going from 100% on the left, we go down to only 8% of our at-risk respondents who had taken PrEP. So that's very low. Among the PrEP users, half of them have or had taken PrEP in the context of a PrEP study, and the rest had used PrEP outside of a PrEP study. So when you visually look at the cascade, what you can see is that you have two main gaps. Here, knowledge, so information, and the second one is here, in terms of access. So then we wanted to understand a little bit more about the barriers, so we asked people what could be the barriers for them, and I'll present barriers here among respondents who declared being potentially interested in taking PrEP. And you have the individual barriers on the left and the structural barriers on the right. So what you can see is that the main barrier is the fear of side effects, with up to 55% of the respondents in one group who said it could be a barrier for them. The second one is the need to go to the hospital to have access to PrEP. And the third one is the need to undergo regular medical checkups. You also had taking medication every day and the potential need to pay for PrEP. Then we also had the barriers among respondents who declared not being interested in taking PrEP. And we focused on the persons among those ones who were at risk, using the criteria previously mentioned that we don't really agree with. And that's the same presentation, individual barriers on the left and structural barriers on the right. So what you can see here is that as for the other group, the fear of side effects was the main barrier. The second one was taking medication every day. And the third one was the feeling that they don't need to change how they protect themselves. So that's in relation with risk perception. You also had the fear of getting other STIs, the need to undergo regular medical checkups, and the need to pay for PrEP. So now, to wrap this up, we wanted to do a community-based research project to identify people's needs. And what we can see here is that PrEP knowledge among at-risk respondents is surprisingly low. There was a quite high interest in PrEP among this group, but very low uptake. So the two identified gaps in the cascade were information and access. In terms of barriers, we identified the following barriers: side effects, the need to go to the hospital, regular medical checkups, and risk perception. And something that we need to all have in mind is that whether officially available or not, at-risk populations are interested in taking PrEP when they know about it, because it's very hard to be interested in something when you don't know about it, and they are doing everything they can to get it. So now I'm removing my researcher cap and I'm putting my advocate cap. So here's what we ask for. First, listen to people's needs regarding PrEP. The second one, to scale up access to PrEP to all exposed populations in all European countries. And the first step would be to make PrEP officially available in all European countries. We all know that we're far from being there, and that's not something that we can accept. It needs to be delivered inside and outside hospitals, because we saw that going to the hospital to have access to PrEP could be a barrier for some respondents. We need to develop training programs for all healthcare providers so that they all know about PrEP, they know how to talk about PrEP, they know how to talk about sexual health, They can identify people who might benefit from PrEP, and we stop missing opportunities. And of course, we need to involve community-based organizations in PrEP provision, get these people on board. They know how to talk about sexual health, about harm reduction. They know how to support people in their PrEP taking. They absolutely need to get on board. And last one, improve PrEP information and communication. We've seen that it's a main gap. So it's both in terms of quantity and quality. People need to know about side effects, about the various regimens, about how you can access to PrEP, and it needs to come from various sources, of course institutions, but also CBOs and medical providers. And I will end saying thank you. Thank you for your attention. Thank you to the more than 15,000 survey respondents. And thank you to all the partners who have been involved from the start and without whom nothing would have been possible. Thank you very much.
Thank you very much, Adeline. Our next speaker is Darrell Tan. He is an infectious diseases clinician. Clinicians. Question? No. Okay. Sorry. You have opportunity to ask some question. So I thought that it would be at the head of the session. Go ahead.
Oh yeah, hi, Markowitz from New York. Did you differentiate between daily oral PrEP, PrEP on demand, or some of the newer, like long-acting formulations as far as people's willingness to use?
So in the survey, we had some data about the regimens. We asked if people were taking PrEP daily or on another form of regimens. We didn't ask about long-acting injectables or any other form of long-acting use. And, well, I didn't want to go through all of this in this presentation because it was not the main topic, but yes, we have some data about that. And it should be published soon.
Adeline, thank you very much for the presentation. Terrific job. Edwin Schalboy, UCSF. I have to ask, what was the German recruitment strategy? Did it involve incentives, or what was?
No.
Obviously, there must have been a different channel.
Yeah. So in Germany, the community-based organization we worked with could actually ask some personal messages to people connected on Planet Romeo. And instead of banners that we used for the other countries on this website, on this site and this application, in Germany they could actually send personal messages to everyone who was connected. So it was way more effective in recruiting, and we had more than 1,000 people in a few days. So it's a very effective way of recruiting people, but we couldn't do that in the other countries. So it came out that it was quite an unbalanced sample.
Thank you. That's very informative. Great new tool to reach people directly.
Yeah. But what is really interesting about that is that the samples are quite different in Germany and in the rest of the countries. So we have very interesting data to compare, because the German sample is way more representative of a global population of people connected on these websites.
I have one quick question. Do you plan to do the survey again? Because it would be good to track information and access in Europe in the future.
That's not planned yet, but that's something that we could do. There will be the MS survey, the new version with PrEP questions. So that will give a lot of data, about MSM, but that's the majority of our sample. So we could be able to compare some of this data with the IMIS survey, the new version.
Thank you.
Let's go to...
Sorry.
Hi, it's Gus Cairns. I was a bit involved in Flash PrEP, as you know. Two things really stand out from your PrEP cascade. One we know about already. Lots of people who want PrEP in Europe can't get it, but we know some of the reasons why. But the other big thing, and this has been coming out through PrEP studies all the way this week, is that lack of information, and also the thing that people do not see themselves at high risk. And I wondered about your thoughts about how we sort of get around that, really. And this is really for the whole panel rather than just you, I think.
Yeah, that's indeed something that we see here, and that's something that we see in the other models that we've been doing on this data. I really think that community-based organizations are the main stakeholders that could help people in evaluating their risk, evaluating their sexual health, their sexual practices, how they include that in their sexual life, and that's why they need to be on board in PrEP provision. I really think they have some major role to play in that.
Okay, thank you. Let's go to our second speaker, Darrell Tan from Canada. He is an infectious diseases physician, clinician scientist at Canadian Institutes of Health Research, a new investigator whose research focuses on clinical trials in HIV prevention and HIV-STI co-infection. Welcome.
Great, thanks very much for the introduction. Bonjour tout le monde. Good morning. I'll wait for the slides to appear. Okay, there we go. Okay, here we go. Thanks very much for the opportunity to present this work on behalf of my co-authors. These are my disclosures. So we've been hearing a lot over the last few days about different formulations of PrEP, or what we might also call new HIV prevention technologies, I'll call them NPTs, that are currently in development, each with unique attributes or characteristics that we could expect would appeal differently to different individuals. So some might prefer a long-acting injectable if that becomes available, others might like a rectal microbicide, etc. And understanding these sorts of preferences could inform how providers at the front lines discuss and frame these NPTs with their clients or patients, as well as how policymakers think about projecting uptake and eventual impact at the population level of these interventions. Within the field of marketing research, and subsequently taken up by health economics, there's a methodology called a discrete choice experiment, or a DCE, that actually seeks to explicitly quantify these preferences. And it involves a number of steps as listed here. The first is to identify a number of attributes of interest. So we might think about, for example, the route of administration of a form of PrEP. Second, one needs to assign different levels to that attribute. So we could think about a pill, we could think about a long-acting injectable, etc. One then creates scenarios that combine these different attributes and levels together, and then asks participants in a study to choose between different sets of scenarios. And then ultimately at the analysis stage, one can actually quantify the trade-offs that participants are making between the different attributes that you're looking at in the study. So we use this design, a DCE, to characterize preferences for new prevention technologies among gay, bisexual, and other men of sex with men in Toronto. We did this by nesting it within an anonymous survey that we were conducting among adult MSM undergoing anonymous point-of-care HIV testing at a busy downtown sexual health clinic called Hassle-Free Clinic in Toronto. This is the site that has the highest HIV positivity rate among all of the anonymous HIV testing sites in the province of Ontario. The DCE itself involved 12 what we call choice sets, each of which presents the respondent with 3 different options. So the first 2 are hypothetical NPT options that combine those different attributes, and the third is what we call their usual methods to prevent HIV infection. We excluded TDF FTC-based PrEP. So this really refers to things like seropositioning or condom use, etc. The NPT options differ then according to 4 different attributes that we selected. So the first was the route of administration and frequency, which we said could either be a daily pill, an on-demand pill, a monthly injection, or an on-demand rectal gel or microbicide. Secondly was the HIV prevention efficacy, which we set at either 50, 65, 80, or 99% risk reduction. Third was side effects, which could either be absent or mild, and the mild side effects were tied to the specific formulation. So we assumed that the pills could potentially cause mild nausea, the injection could potentially cause mild injection site reactions, and that the rectal gel could potentially cause mild rectal discomfort. And then finally was the risk of resistance, which we operationalized by saying that the option could have a no, low, or moderate chance of decreasing the person's future treatment options. So this is what an example of one of those choice sets looks like. You can see we asked the person which option they'd prefer among A, B, and C. The first 2 are the 2 hypothetical NPT options. The third is their usual methods to prevent HIV. And you can see how we tried to highlight how the different options differ from each other with respect to those attributes that I mentioned. After we conducted a pilot phase looking at the responses from the first 62 respondents that we had to make sure that the questions were understandable and making sense to people, and as well that they were actually making trade-offs between these different options that we were giving them. and then performed mixed logistic regression in order to infer the relative preferences for the attributes that the respondents had and to estimate the heterogeneity within the population. We then took the beta coefficients from the model and then linearly transformed them in order to make the results more understandable, as I'll show you in a moment, so that we assigned the least preferred combination of NPT attributes a score or a utility equal to 0, and then the most preferred combination of attributes we assigned to have a utility of 100. Separately, we also conducted latent class analysis in order to identify response patterns within the data. So after completing the pilot, we had a remaining 306 respondents, out of which we had to exclude 53 for various reasons shown at the top here. And the table shows you just a quick snapshot of some of the characteristics of our respondents. So the median age was 31. Most were white, but there was a decent amount of heterogeneity within the ethno-racial categories that reflects the population of downtown Toronto. It was a highly educated population. You can see the risk activity here, the median and interquartile ranges. And you can see that the vast majority of the respondents were aware of TDF-FTC-based PrEP. So this is the result of what the mixed logistic regression spits out after we linearly transformed the coefficients. You can see each of the attributes and levels listed here on the left, each associated with a coefficient and a 95% confidence interval. I'm going to remove that last column to make some more space and then walk you through a couple of examples to illustrate what this tells us. So as I mentioned, we assigned the best combination a value of 100, and that best combination turned out to be an on-demand pill that would cause no side effects, have 99% risk reduction, and have no risk of resistance. And if you add these scores up together, you get a value of 100, which is what we assigned it to equal. In contrast, the worst combination would have been a daily pill that caused mild side effects, had only 50% efficacy, and caused a moderate risk of resistance. You add these numbers together, you get a utility score of 0. And then every other hypothetical NPT that you could think of would have a score in between these two values. So for example, if we thought about a monthly injection that caused mild injection site reactions, had 80% efficacy, and a low risk of resistance, you get a utility score somewhere in the middle, 64.1. In contrast, if we had a rectal microbicide gel that had the same characteristics, mild side effects, 80% efficacy, low risk of resistance, you have a new lower utility score, meaning that on average, the participants in the study would have chosen the injection over the rectal gel, but neither of them would have been preferred as much as the optimal scenario that I showed you a moment ago. If you take those numbers from the table and then just present them in this graphical form like this, there's a couple other points that become a bit more obvious. First of all, just for reference, no PrEP has a utility score a little up under 50. And you can see that of all the different attributes that we were looking at listed at the bottom here, the one that really seemed to drive the responses or drive the utility scores was the efficacy. And you can see that clearly a higher efficacy was associated with a higher score, which is what we would have expected. In the next 4 pairs of dots over here, you can see if you, these 4 dots, sets of dots represent the 4 different formulations. If you just ignore the dots that say side effect or SE for the moment, you can see that among these 4 sets, the purple dots, or the purple no side effect dot is the lowest, meaning that on average, people prefer the on-demand rectal gel least compared to the other 3. Once you add in the presence of side effects, however, you can see that obviously the score goes down a little bit, and that's most marked for the daily pill with a really wide confidence interval here. Presumably this decline is because people really didn't like the idea of taking something daily that would be causing side effects all the time. Now, another way to look at this data is to think more explicitly about the trade-offs that the respondents were making between the different attributes that we were asking about. And because one of our attributes was a continuous variable, the efficacy in reducing HIV risk, we can ask the question, what is the minimum efficacy that a strategy would need to have in order for people to prefer that option over not taking PrEP? And you can see that the threshold was lowest for an on-demand pill. People would be willing to take this over not taking PrEP as long as it decreased the risk of acquiring HIV by at least 50.5%. And in contrast, they would demand a much higher degree of efficacy if they were going to be willing to take an on-demand rectal gel, 76.2% or higher. Now, a limitation of the way I've been showing you the results so far is that we've been, of course, assuming that every person in the study has the same preferences. And of course, we would expect that that's not going to be the case, that there's going to be some heterogeneity. So an advantage of this modeling technique is that it allows us to explicitly model that heterogeneity. So for example, if we think about the score associated with not taking PrEP, I showed you a moment ago that the average score was a little under 50, 47.3. But in fact, there's a whole bunch of, there's a distribution around this and a lot of variability. So you can see that shown here, that about a quarter of the population really had really low scores associated with not taking PrEP, implying that they'd probably be very willing to take PrEP. And in contrast, there's another about 1/10 of the population who has such a high score associated with not taking PrEP that we can interpret them as having a strong aversion to taking PrEP. And everyone else lies somewhere here in the middle. So as a last step, in order to understand that heterogeneity a little bit better, we undertook latent class analysis. And this identified 4 subsets of participants, shown here, 1, 2, 3, and 4, representing about 2/5, 1/5, 1/5, and 1/5 of this total sample. And what I'm showing you in the table for each of these attributes or formulations, with or without side effects, is again those same numbers, the minimum efficacy required for respondents to prefer that strategy over not taking PrEP. So in order to make a little bit more sense of this, if we look at, for example, this first class over here, you can see that this group really needed virtually no convincing in order to take a pill, whether it caused a little bit of nausea or not, over not taking PrEP. In contrast, the second group had demanded such a high degree of efficacy before they'd be willing to take one of these new prevention technologies that they're essentially averse to all of them. The third group really had a really high threshold for taking the rectal gel, but would be more willing to take the other, so they're kind of averse to the idea of a rectal gel. And then the last group is maybe a little bit more ambivalent with scores that vary across the different options. So this work obviously has a number of limitations. The social context in which we conducted the study was Toronto in Canada last summer, a setting in which the social acceptability of PrEP among gay men was probably, I would say, modest but slowly rising. We obviously had to make quite a number of simplifying assumptions, including that the severity of side effects was always mild. And of course, we only looked at the 4 attributes that I told you about, and there may be other attributes or characteristics that are equally or even more important to users. And then finally, any work like this is subject to something called hypothetical bias, which simply means that the choices that people might actually make in real life could, of course, differ from what they tell you they would do when you're asking them the question hypothetically. Nevertheless, we think that we can conclude that attitudes towards these emerging PrEP formulations among MSM are clearly heterogeneous, and I showed you what the most preferred and least preferred hypothetical options would have been in our sample. And we can also conclude that the HIV prevention efficacy was the primary driver of utility. Ultimately, though, we think that work like this that tells us about preferences or aversions towards specific routes of administration and other characteristics can affect uptake of different interventions as well as adherence to them, and would be useful for us to consider as different prevention technologies make their way towards real life. With that, I'd like to thank all the participants in our study and our funders. Thanks very much.
Thank you very much, Darrell. Any question? Yes.
I don't think it's on. Is it? Okay. Ben Ryan from Pause Magazine in the United States. I'm curious how you describe to them the on-demand protocol. Like, it's rather convoluted when I try to describe it in my magazine, but I'm wondering how things might change as we get a better understanding about how that works with people taking sex infrequently, as we have at this conference, and also perhaps one day we'll have a single pill you take before sex and how that might affect uptake. Obviously, you didn't test for that, but I'm curious for your ideas.
Yeah, thanks for the question. So we had an in-person research coordinator who was actually administering the survey. So this was done in person such that they were able to describe in a bit more detail what we meant by a pill before and after sex. However, it's true we didn't, for simplifying reasons, we didn't explicitly describe the hypergay strategy. We just said, a pill that you would take before and after sex and left it at that.
Thank you for the very nice presentation. Ariane van der Straten, RTI International. I had a couple of questions. Number one, I was wondering how you presented, and maybe it's a good follow-up to the previous question. Well, how do you present a different product? Did you have a video? Did you have sort of picture or so forth? Because definitely that would influence end users' response. Particularly, I was interested to know how you presented an injection. Did you discuss the lead-in and probably extensive need for pills for the PK tail, or not?
Excellent question. Thanks very much. I wish the short answer is no. I wish we could have done that, but for simplifying reasons, this was kind of exploratory work. I agree that other DCEs often present people with actual examples, so to try to reduce that hypothetical bias, you show it to them to make it more real, but we were unable to do that in this work.
And then, I wanted also to ask you a clarifying question. It was very interesting the way you did your analysis about how the utility of the efficacy. So in one study we've done, we've also seen that overwhelmingly efficacy is driving preference. But I think that it's a very, I mean, can you explain more about how you did your analysis where you looked at the level of efficacy given all the other attributes? Because that really informs the kind of product that may be more easily taken and used by population given the other consideration.
Yeah, I won't go into the detailed biostatistical methods right now, but essentially the analysis that we did is analogous to what's often more commonly done in health economics analyses, which are willingness to pay analyses, where you have a continuous variable, usually cost, and they can weigh that against the others. Here we used efficacy because, again, that's continuous.
Thank you.
Sorry, just only one question back.
Mitchell Warren from AVAC, and a great presentation. Two quick questions. One, did you describe at all the assumed efficacy of the no PrEP, so the baseline, and what were people's expectations? And also, I was going to ask about cost and what was the rationale for not incorporating cost, which you just mentioned, but I'd love to hear more about that.
Yeah, great. Thanks for the question. So in response to the first issue, we did not specify an absolute level of risk. We said that all of these interventions, these hypothetical interventions, would reduce your existing level of risk by X%. So really the concept of risk reduction. And then with respect to cost, we explicitly chose not to include that into our model. The reason really being that in Canada we have a universal healthcare system, so that health care is universally covered for residents. Granted, we don't have a universal pharmacare program, which is a huge problem, but we did assume that people would ultimately not likely be paying for these products out of pocket. Even for TDF-FTC-based PrEP at this time, people who are accessing it are doing so using private drug coverage. We're hopeful that there would be public drug coverage in the province of Ontario in the future. And so for that reason, we thought it wouldn't be realistic to ask people to think about the costs that ultimately they were unlikely to be really shouldering entirely on their own in the future.
Thank you, Darrell. Let's go to the next speaker, James Ayokwe from Kenya. He is a medical doctor working in SAGE trial, evaluating the efficacy of test and treat approach in HIV care. Welcome.
Thank you so much for the introduction. We thank, I'll be presenting on early adopters of PrEP within the SAGE study. So PrEP is now recommended for high-risk persons in Africa. However, there are limited data on PrEP uptake in Africa. Most of the data comes from clinical efficacy trials. Where we do not have data is PrEP uptake in the new context of test and treat programs, as well as looking at populations as a whole. What I'm going to talk about today is an analysis of early PrEP adopters, and I hope that this is going to provide insights for program strengthening as we roll out PrEP. So the SAGE study is an ongoing cluster randomized trial involving over 320,000 persons in 32 communities spread in rural Uganda and Kenya. SAGE is a two-phase study. In phase 1, we conducted population-based multi-disease test and treat, and we exceeded the 1990 UNAIDS targets as was presented in Durban last year. For phase 2, we added on targeted PrEP, HIV testing, and cascade optimization. So for our population-level PrEP intervention, we conducted community mobilization and sensitization, followed by community-wide testing using our community health campaigns and home-based testing for those who did not attend our health fairs. So we offered PrEP to two groups of persons. One was a risk group, was a high-risk group based on an empiric score, and I'm going to talk about that in a minute. And secondly, those who self-refer themselves based on the knowledge of their risks. So for instance, someone who would say, I know my risk and I want PrEP. The objectives of this analysis is to report on the initial PrEP rollout in 5 of our intervention communities. Remember, our context is an ongoing test and treat setting with population-level assessment of HIV risk exposure. What I mean by that is that we virtually tried to evaluate risk status among the entire community using our testing strategy. So we sought to describe early PrEP adopters, defined as those starting PrEP within 30 days, their characteristics, and the predictors of early PrEP uptake. Our analysis population included adults aged 15 years and above, resident in one of our 5 intervention communities in Kenya and Uganda, eligible for PrEP by self-assessment or by a risk score that was based on age, gender, marital status, polygamy, education, and so on. But at this point, I just want to say that the risk score was developed to maximize coverage of seroconverters and minimize the number of people we have to offer PrEP to. You think about it as more of a balancing act. So for statistical analysis, we assessed a 30-day cumulative probability of initiating PrEP and the characteristics of early adopters by way of logistic regression. So the slide projected summarizes the PrEP uptake numbers in our analysis. As you can see, 21,000 individuals were identified to be HIV negative. 4,064 of these were identified for PrEP. That broke down to 74% based on risk score on your right, and 26% by self-assessed risk. I'll talk slightly more about the flow on the right side. Of those identified based on the risk score, 11% were early adopters and 78% of them started PrEP on the same day. Of those who self-referred, now on the right, 39% were early adopters and 77% of these started PrEP on the same day. So the following were the characteristics of the 4,064 individuals identified for PrEP. Males comprised slightly more than half. About half were aged 18 to 25 years. 2/3 had primary level of education, and 3/4 were tested at our community health fairs versus home-based testing. So what did the timing of PrEP uptake look like? The bar graph, as projected, shows the cumulative PrEP uptake by day since the contact date. The red bar represents those who self-referred, while the blue bar represents those who were identified using our risk score. The graph shows that most uptake occurred on the day of contact, with minimal additional uptake over time. Here's what it looks like on a Kaplan-Meier curve. And as you can see, the difference here is, I guess you can notice the difference, a big difference in proportion between those who self-identified, shown in red, and those who were identified by the risk score, shown in blue, in terms of who started PrEP. But as you also notice, the timing does not show a difference. So I guess suffice to say that there's something about self-perceived risk that plays into this equation. So at evaluation, we asked participants their self-perceived risk prior to PrEP and HIV result counseling. Only 30% of those identified by the risk score perceived themselves at risk, while 49% of those who self-referred eventually perceived themselves at current risk. We then proceeded to offer PrEP education and counseling. So what were the predictors of early uptake of PrEP? So this slide shows the result among those who were eligible via our risk score. On our multivariate model, being male, being in a polygamous relationship, being in a serodiscordant relationship, perceiving yourself at current risk of HIV acquisition, and being tested at our community health fairs were associated with higher odds of initiating PrEP within 30 days. Having a secondary level of education was associated with lower odds of initiating PrEP within 30 days of contact. Now we look at the predictors among those who self-referred. We observed a linear increase in the odds of initiating PrEP with increasing age, though we lose that association on the multivariate model, as you notice on your right. Our multivariate model shows that being older was associated with higher odds of initiating PrEP within 30 days of contact. However, any level of education versus none, being tested at our community health fairs, was associated with lower odds of initiating PrEP within 30 days of contact. So in summary, we had 739 early adopters in a population-based approach in rural Uganda and Kenya. Majority started PrEP the same day as offered, and among those who were PrEP eligible by risk score, only 30% perceived themselves currently at risk prior to counseling, and after counseling, only 11% started PrEP within 30 days. Among those PrEP eligible by self-assessment, 49% perceived themselves currently at risk prior to counseling, and after counseling, 39% started within 30 days. In conclusion, population-based PrEP delivery and uptake is acceptable and feasible in real-life rural African setting. However, barriers to PrEP need to be addressed with new approaches because majority of the persons identified as high risk using our score neither perceived themselves at risk nor were they early adopters. As a study, we have ongoing efforts to address barriers and optimize PrEP continuation. So here are some related poster presentations from the search study addressing barriers to PrEP uptake, as well as an evaluation of PrEP demands among adolescents, young adults, and serodiscordant couples that may interest you. These will be presented later this afternoon. We would also like to thank and acknowledge our funders, our partners, and our collaborators. Thank you.
Thank you very much, James. Any question?
Thank you. I'm Ashley Grosso from Public Health Solutions. I was wondering the rationale for not including sexual risk behaviors or membership in key populations as part of the risk score.
The risk score was more complex than the variables that I've included there, but definitely that was also included. Yes, thank you.
Achemidel. Yes?
I have a question related to the risk score as well. How accurate can it be in terms of assessing the real risk? And the same question about self-assessment. Sorry, I'm Sarah Van Rompuy, Friends in Global Health in Mozambique. Mozambique is going to implement PrEP as well. And we are having these discussions on who should benefit from PrEP and how to identify the real risk in a setting where the incidence is relatively high in the general population.
Yeah, thank you for the question. I think, so what we factored into the risk score was what we had observed from phase 1 of the study, the pattern of new infections over a period of time, and we felt pretty confident that if we've seen these characteristics over time, then they're likely to predict who is likely to be infected next. So it's a first attempt in terms of, leading the way in terms of designing designing methods that you can use to tell this is a person who will benefit from the risk score. It's not perfect, but I think it does the work.
Yes, madam.
All right. Thank you very much. That was a wonderful presentation. My name is Elizabeth Irungu from Kenya. My question is, did you apply the risk score on the people who came in having perceived themselves to be at risk? And did you find whether or not they were at risk or are just worried well coming up for PrEP?
Yes, we applied the risk score to everyone. And yes, in a normal population, you'll also have the worried well who will just require reassurance that that is not a valid risk to go on PrEP for. But yes, the answer to your question, we applied it to everyone.
Back, please. Yeah, 9.
Congratulations. This is really pioneering work. Two questions, really. One is, how do you explain why the uptake was only 33% among those who came to the clinic having self-perceived a need for PrEP? So that's one question, the low, 33% uptake in those who came in wanting PrEP. And then the second is, it looks like there were 20,000 people potentially evaluated, but only 4,000 were judged to be candidates for PrEP. And what kind of filter or screen was used to get from 20,000 to 4,000?
Okay, so I'll start with the second question. Maybe the moderator will remind me the first one. Sorry, I did note it down. For the second question, our filters were, we applied the score, the risk score that we had developed, and it was able to tell us who is ineligible for PrEP. We refer to them in this presentation as the Rs. And if you are not an R, you were given the opportunity to opt as an S or a self-referral. So those are the steps that we followed. And as I had said, the risk score was developed based on what we had observed in the first phase of our study. And we felt like it's a good risk score to predict who is likely to be infected. And we thought that's where it may be of value to put investment in trying to prevent new infections. Second question, please, moderator.
I think we're going to spare you the second question because we're running behind.
Okay, thank you.
Thank you, everybody. It will be really interesting to see this develop in search as it goes on. Our next speaker is Edwina Wright from Australia, who will be talking to us about PrEP rollout in Victoria.
Good morning. It's a great pleasure to be here this morning to talk with you about health systems and study design features that permitted us to rapidly enrol individuals into a PrEP trial in Melbourne, Victoria, Australia. These are my disclosures. Australia, in the Antipodes, we have 24 million people with an HIV seroprevalence of about 1%. Like France, we have the great fortune of having free healthcare with Medicare. We have a pharmaceutical benefit scheme which subsidises medications for Australians, excuse me, and that sees an individual at the time they get their script having to pay a relatively modest co-payment for each of the scripts. We have national PrEP guidelines. We have tenofovir and emtricitabine registered in Australia with 3 pharmaceutical companies, but they're not yet subsidised. We hope to have a positive outcome for that in the very near future. We have 12,000 people on PrEP in trials in Victoria, South Australia, New South Wales and Queensland, and I just want to emphasise the triumph of enrolment in New South Wales, over 6,500 people, nearly 2,000 people in Queensland. In Victoria, the capital state is Melbourne, which is a fast-track city. We have about 6,000 people living with HIV. And last year we had 323 new diagnoses, and about 40% of those we could identify with people who had newly acquired HIV. We've been active as a state with PrEP for some time. The Vic PrEP study was the first PrEP study to be undertaken in Australia, and we've had a lot of activism for several years, seeing things like online websites are put up that allow individuals to self-import reliably safe and low-cost PrEP. We have activists putting together online educational ports. We have an accord, a PrEP accord between activists and researchers and peak organisations, and other programs that look at the benefits of PrEP and treatment as prevention. We have a high rate overall of people importing PrEP into Australia, which is a right of ours to do so. And this has led to, similar to the flash PrEP data we just saw, just a few days ago, data released showing that 77% of MSM in Melbourne who were surveyed were aware of PrEP, so high background health literacy. And that brings us to the PrEP-X study that I'm discussing today. It commenced in July 26 last year. We've enrolled over 3,000 people to date. It's a population intervention study which is designed to emulate real-world conditions as if the drugs were already subsidised and one would just be free to go to a doctor and get their PrEP. The primary aim of this study is to determine if the provision of daily generic tenofovir and emtricitabine to 2,600 people at high risk of HIV infection in Victoria would lead to a 30% decline in new infections in MSM and an overall decline of 25% in the state. I just want to mention that we've also taken the study to South Australia just in May, and already they have enrolled over 300 people. The sample size of 2,600 individuals, to discuss that, each year, as I mentioned, we diagnose around 100 or so Victorians with HIV acquired in the previous 12 months. However, if you do back calculations using notification and surveillance data and modelling, in fact, it's probably more like 300 new infections occurring in the state each year, 75% of which occur in MSM. And we thought that to avert a third of these infections in MSM would be a meaningful population prevention outcome. This number of participants provides 37% of coverage of the population at risk. We estimated that about 7,000 Victorian MSM are at high risk. We felt the study was feasible based on the terrific work led by Martin Holt with his PREPARE surveys, whereupon he informed us that about 38% of Victorian MSM were both willing and eligible for PrEP. I want to emphasise the early engagement with the community and clinicians, even prior to funding surety. I think that was absolutely crucial. We initially had 7 metropolitan clinics in Melbourne. 2 were sexual health centres that provided free care for participants. 1 was a tertiary referral hospital clinic, which also is free to participants. We had 4 private general practices, one receiving rebates alone from the government to see patients, and the other clinics receiving the Medicare rebate, but also asking patients to pay an additional fee, which is common practice in Australia. We offered the clinics either a $100 remuneration per participant or a study nurse to help support them with the study, and all clinics chose to have the financial remuneration. We had 7 pharmacies involved. 5 were retail and 2 are clinical trial pharmacies, and we had to obtain ethics permission to engage retail pharmacies in the study because in Australia one never runs a clinical trial through a retail pharmacy, and we were fortunate enough to get that approval and went ahead and paid the pharmacists to do good clinical research practice and established appropriate conditions in the pharmacies. So what that meant was that patients could leave their clinic, walk across the road to their usual pharmacy anyway and get their PrEP-X script. At the time that happened, the pharmacist would receive a co-payment from the participant for each of the PrEP-X scripts. Study visits were baseline and quarterly HIV, STI testing, clinical evaluation, laboratory testing, and eligibility was per the 2015 National PrEP Guidelines. And we also had we permitted clinicians to use their discretion as well about enrolling individuals. So, when funding was announced in January of last year, we immediately established a registry using Research Electronic Data Capture System, the wonderful REDCap system. And in doing so, we asked individuals to go online to register. They gave us their contact details. current or previous PrEP use, which of the study clinics they would prefer to go to, and whether indeed they were already a patient at that preferred clinic. So when the study opened in July of 2016, we notified the participants about a week or so before, encouraged them to contact the clinic they wanted to go to and make an appointment, and we were able to advise the clinics on exactly the number of participants that they could expect, the proportion who are already on PrEP and therefore health literate, and the proportion who are already patients at that clinic. We also had to establish a couple of waiting lists, as you'll see during the study, because we quickly reached the 2,600 number, and until we received funding boosts in January and March, we had to put people on waiting lists. So and we got funding to enrol up to 3,800 people. So in a sense, we actually experienced 3 waves of enrolment. The baseline enrolment survey, all serious adverse events, withdrawals and participant transfers between study clinics were all captured electronically, but doctors wrote and nurses put all of that in online. And HIV, STI and laboratory results for 5 were captured through the access system. Here, 5 of the study clinics already participated and provide de-identified HIV and STI test results to this national surveillance system. And for the purpose of our study, we were able to re-identify those individuals and get their test results. In 2 studies, we had manual data extraction. So, this is the analysis period, 26th of July of last year till April 30, 2017. During that period, we enrolled 3,137 participants. We enrolled 1,000 people in the first 3 weeks and 2,000 in the first 10 weeks. So on this y-axis, it's the number of people going on a waiting list or the registry, and this y-axis is the number of people enrolling. So here we get funding announced in January of last year, and you can see each week the number of people putting their name down who are interested in the study. Here the study opens. At that time, 2,049 people were on the registry, and just so you know, about 2/3 ultimately did enroll into the study, so the registry may be an indicator of actual uptake. Here's the 1,000 people at about 3 weeks. Here's 2,000 at 10 weeks. And then here you can see we had to open waiting lists because we were approaching our 2,600 limit and we couldn't over-enroll. And then you see we get new places opening up with a funding boost, and then a second funding boost happened, so we sort of had this 3rd wave of enrolment that I mentioned. Just wanted to share with you that about 25% of people thus far actually came to us already on PrEP. So here it's the same graph, but this is where the study opened. And in the blue horizontal lines are the individuals who were already on PrEP when they enrolled in, importing PrEP, when they enrolled into the study. And you can see most of the people importing PrEP enrolled in the very early days, and then as time went on, people were less likely to be coming to us on PrEP. They were PrEP naive. Now, where did people enroll? So we had a total of 7 clinical sites. The vast majority enrolled in the GP clinics. They have enrolled about 2,000 people during the study period. And you'll recall that 1 just took a Medicare rebate and 3 asked patients for a fee. So it's really essentially like a private model. The sexual health centres enrolled about 500 people, and our hospital enrolled about 250. And I just want to illustrate that free systems can expand. So at the wonderful and very busy Melbourne Sexual Health Centre, it's actually normally a free walk-in service. That's what you get. But in order to participate in the study, they established an appointment model. They got Medicare rebates, and they were able to create 2 all-day clinics each week. At the Alfred Hospital where I work, we had already 1 free prevention clinic up and running, but for PrEPX we established nurse-led clinics that ran 5 days a week for several weeks just to try and enrol people into the study and off that initial waiting list. It's now running 2 days a week. This is the final data slide. So this slide relates to those 5 access clinics where people attending the clinics have their data anonymously collected. So on this y-axis, it's the number of HIV tests. On the x-axis is months in year, and this red arrow shows you when the PrEP-X study started. So this actually reflects 12 months prior to the PrEP-X study starting, and this is the months after. So in blue, what you're seeing here are average number of monthly test results performed in MSM at these clinics who ultimately went on to enrol in the PrEP-X study. So you can see before the PrEP-X study opened, there was an average of 210 tests performed in those MSM, but that went up considerably because they went on to PrEP. And in fact, you can see those kind of lovely peaks of the quarterly visits and having the HIV tests. But importantly, for the MSM attending the clinics who decided not to go on PrEP, and we've heard not everyone does want to, at least for now, the average number of tests of HIV tests in those MSM was 378 per month, and that didn't change. So what we think this tells us is that the clinics were able to continue to provide appropriate HIV testing for their patients who were not going on to PrEP, despite having a large number of people to test and treat for STIs on PrEP. And we saw a similar pattern for syphilis tests in these clinics and also for Neisseria, gonorrhea and chlamydia. So we were heartened by that. So in summary, we think features that may have contributed to rapid enrolment were those that were already in situ. Medicare, PBS, national PrEP and STI guidelines are very useful because they're Medicare rebatable. If you have guidelines, we can justify it as standard of care. We had a high background rate of PrEP literacy, a lot of collaboration. I think the study registry was really important. We remunerated and I guess incentivised the clinics and pharmacists. I think that was important. And it was a real world design and it was essentially a paperless clinical trial. The private general practice clinics had the greatest capacity to enrol the participants, and I think they just have greater flexibility. They're receiving rebates for each visit, including people coming back for STI testing. But those clinics offering free services also successfully developed models to build capacity. And we did not observe an impact on the clinic's capacity to provide ongoing HIV and STI testing to non-PrEP-X MSM. These are the references for images I've used. These are the many acknowledgements of the PrEP-X study team, Burnett Institute, Centre for Social Research and Health, the study clinics, pharmacies, access, community orgs, DSMB and funding bodies. I would say particular thanks to Brian Price, to Kat Ryan, a PhD student who did a lot of the analyses, and to the Victorian AIDS Council's board and their CEO, because a community organisation funded us at the beginning and then gave us another injection of funding during the study to get people off the waiting list, which gives you a sense of the camaraderie that we have happening in Victoria. Finally, I want to thank the PrEP-X study participants, researchers and participants from previous PrEP studies, and the non-human primates and other animals who've contributed to our current understanding of the science of PrEP. Thank you, merci.
Incredible. And Gus, you get the one question.
Am I on? Oh, that's better. Gus Cairns from AIDS Map and PrEP in Europe. Fantastic results. For me, your most important side was the one you whizzed past, which was STI testing. I don't know if there's the slightest chance of getting it back again, but
sure.
I was wondering if you'd actually started to see any decline in any STI diagnoses as we seem to be beginning to observe in London.
I don't think we could say we're seeing a decline, but we are not at all seeing a rapid increase, which is really heartening.
And can I be really cheeky and add one more? Was there a standard fee that the people who went to GPs paid or at pharmacies, or did it vary?
Oh, no, that's a really good question. So for the general practices that choose a fee, that get the rebate from the government but have a fee, which I don't want to in any way impugn them for doing that, where doctors are very underpaid in Australia and haven't been, had a pay rise for many years. The fees may be, say, $30, $40 or so per visit. And at the pharmacies, all of us as residents, though non-residents can't get subsidised medications, if I'm on a concession, it's about $6 or $8.80 for a PrEP script for 3 months. That's what we charge, or about $36 for 3 months if I'm not on a concession or a pension. So that's the kind of cost that they were putting out.
Okay, thanks.
Wonderful. Thank you. Okay, our final abstract is now coming up. This is Hannah Zimmerman. And everyone should clap for her because she is a PhD student at the Public Health Service of Amsterdam, and she has sat here for an hour on the big stage waiting to talk.
Well, thank you for this nice introduction. So again, I'm Hannah Zimmerman, and I'm a PhD student at the Public Health Service of Amsterdam. And today I'll present to you my research that I did along with my co-authors, and it's about PrEP among MSM in the Netherlands. And we've analyzed the motives to choose for, switch to, or stop with daily or event-driven PrEP. So these are my potential conflicts of interest. So in the known efficacy of both daily and event-driven PrEP, in the Netherlands we have the Amsterdam PrEP project, also known as AmPrEP, which is a demonstration project for HIV-negative MSM and transgender persons. And at baseline they are offered a choice between daily or event-driven PrEP, and at follow-up they can even switch between these dosing regimens, which is quite a unique feature. So this gave us the perfect opportunity to study the reasons why MSM choose for or switch between these regimens, and why they could stop using PrEP use completely. So as I've already mentioned, we used AmPrEP data. So in AmPrEP, by semi-structured interviews at baseline, motives to choose between daily and event-driven PrEP were collected, and at 3 monthly follow-up visits, participants could indicate whether they wanted to switch or stop using PrEP and indicate their reasons to do so. They could indicate these reasons by using closed-end items or open-end items. So the closed-end items were predefined items, and if a participant felt like the predefined item didn't reflect their personal motive, they could also describe it in their own words. They were creating an open-end item. And it's good to know that more than reason per choice was collected, so we've analyzed more motives than there were participants. We've analyzed, for this analysis, we've analyzed all motives that were recorded from the start of the demonstration project until February 2017. And all open-end items were qualitatively analyzed by using an open coding process by 2 independent researchers, after which we've crystallized and categorized the codes. After that, we've integrated the open-end items with the closed-end items, and we've categorized these into teams. And the teams is what I will present here today. So first, some general results about the AmPrEP. So at baseline, 273 participants chose for daily PrEP, while 103 participants chose event-driven PrEP. In total, until February 2017, we've seen 83 switches, of which 44 switches to daily PrEP and 39 to event-driven PrEP. And in total, we've seen 18 participants who stopped completely using PrEP during that time period. Now on to the motives. As you can see here, we've analyzed 420 motives in 273 participants to use daily PrEP, as shown here in red. And in blue, we've analyzed 206 motives in 103 participants to use event-driven PrEP. And on the left, you can see the teams in which we've categorized them. So those who actually thought that they needed a daily structure or were expecting to have issues adhering to event-driven PrEP chose for daily PrEP, while those who expected to be better adherent to event-driven PrEP chose event-driven PrEP. They've also considered their own perceived HIV risk. So those who were having unplanned or frequent sex thought that the daily PrEP regimen would suit them better, while persons who thought my sex can be planned or I don't have a lot of sex chose for event-driven PrEP. So here's a nice example of sex that can be plannable. So I rely on sex parties as I cannot get sex in general, so my sex is plannable. Others also thought about the safety of the other regimens, so persons who were afraid that they would develop reoccurring side effects from event-driven or feared development resistance with event-driven PrEP chose daily PrEP, while almost 20% of event-driven PrEP users thought that daily medication would put a too high burden on their body. Also, sexuality was considered as a motive to choose between these regimens. So there were people who actually wanted to maintain or gain their sexual freedom, while others actually wanted to use PrEP as a means to control their sexual risk episodes. So for example, for daily PrEP, someone said, I prefer to maintain my ability to have spontaneous sexual encounters, while another person said, because event-driven makes you think about your sex life and then you don't go all crazy. And then there were just others who just wanted to try out either of the regimens. On to the motives to switch, and it's good to know that these are quite comparable to the initial reasons to choose for a regimen, but now these are the actual experiences that could be that are changing during their period of PrEP use. So, for example, their risk behavior could have been changed. So, people who were experiencing increased risk behavior switched to daily PrEP, while others thought that they were having less sex than they had anticipated before, or were just seeking a better match with their current HIV risk pattern, switched to event-driven PrEP. And from either of the regimens, participants developed side effects and thought that this may be less when they switched to the other one. Again, they also thought about the freedom of their sexual risk behavior. So people who were experiencing increasing difficulty to plan sex or just wanted to gain more sexual freedom switched to daily, while even participants switched to event-driven PrEP because they thought it could control or inhibit their sexual risk. In both regimens, people were experiencing difficulty adhering to the regimens. And then I've highlighted this in orange because it's actually not a switcher, it's a daily PrEP user, but I couldn't resist showing it to you. So he said, I was at the countryside where there are no gays, so also no chances on having sex. So this is actually someone who made a well-informed decision about his HIV risk and therefore said, I'm going to temporarily stop my PrEP use. So he thought about it as a periodically PrEP use. And then there were also motives that were specific for switching to daily PrEP. So some of them already had a high usage of PrEP, so there was no point to take it event-driven, or they were having doubts about event-driven PrEP's efficacy. Then 25% of those who switched to event-driven PrEP actually developed an aversion against daily medication, so they wanted to have less of it in their body, or they just wanted to experiment with both regimens. We've also analyzed the motives to stop PrEP use completely, and we've analyzed 20 motives. And the most prevalent one was that they experienced a too high burden on their body, and they felt like these side effects were unacceptable to them. Also, they felt like they didn't need PrEP anymore because of reduced sexual risk, changed life circumstances, or they just prefer to return to condom use, such as this person who said, I need to take medication to prevent something you can also use condoms for. And again, there was one person who actually thought that switching to event-driven was enough to control his sexual risk behavior. He really felt like PrEP use actually provoked the extreme sexual risk behavior, and he didn't like that. So he said, I noticed that I was increasingly going to extremes because of multiple circumstances. PrEP was one of them. So on to the discussion. I think we are one of the first, if not the first, to describe the motives to choose for and switch between these regimens. And we've seen a great variety of motives to do so, mostly based on adherence expectations or actual experiences with it, or anticipated an experienced physical or sexual impact that the dosing regimen can have on them. So we think this underscores the importance of offering a choice that fits changing personal risk and adherence strategy among PrEP users, and we think that both event-driven and the daily regimen offer viable solutions to cover this. So essential for successful implementation to support PrEP users, we think that there should be a tailored approach in which choices for PrEP regimens are addressed as a continuum of flexible and changeable choices over time. And then I'd like to acknowledge, of course, Professor Joep Lange, who was the founder of the AIDS team, and of course all other partners and funders. And last but not least, I want to thank all of my colleagues of Team Research and STI Clinic of the Public Health Service of Amsterdam, and in specific those 4 on the picture who've collected all of the data. And last but not least, and most importantly, all MPrEP participants.
That was fantastic. We're open for questions. Microphone 1, I think.
Test. Yeah. Ben Ryan from Pause Magazine in the U.S. I really haven't heard anything from scientists about what kind of specific side effects people experience when taking PrEP relatively sporadically with on-demand PrEP. I wonder if you could describe that a bit anecdotally. I would think that maybe if you're supposedly, you have headaches or nausea after a month of PrEP, it goes away. But if you keep having these bursts, what were people telling you? And also, how did the clinicians sort of work with them, say like, oh, take it with food, or these are ways you can manage nausea? Is that something that was in your practice?
So your question is really related to the event-driven PrEP regimen? Okay. So there were people who actually said that they felt like, because it's a 2-dose, they take 2 pills before their sexual risk episode. So they really felt that this actually triggered some extra side effects. So they were lightheaded or experiencing nausea, as you already said. I actually am not sure how they counsel these participants on this specific topic. But yeah, the 2-dose really gives them some extra reoccurring. So
it doesn't dissipate with increasing use?
Yeah, I think for some maybe they're getting used to it. So, but it's with on-demand PrEP, it's specifically that, of course, for each sexual risk episode that they plan, they have to take this 2-dose before. So it could be that they, from this reinitiation of the dosing regimen, they keep experiencing these side effects.
Microphone number 3, Wakefield.
Wakefield from the HIV Vaccine Trials Network. Thank you, Hannah, and everyone for really great presentations. I'm wondering what you knew about the participants' perceived vulnerability or risk prior to offering them PrEP, and if they were accurate in their perceptions of risk, and what the frequency of testing was prior to the time that you offered them PrEP.
I actually don't know that from the analysis that I did right now, but since June we've started qualitative interviews, and that is, of course, a topic that we'll discuss.
And last question over here. Number 6.
Very wonderful presentation. I was struck by the fact that all the motivations or the theme you presented were very individual focused. There was not a lot of motivation that was socially driven or partner driven or stigma or social context. So maybe there is a wonderful acceptance for PrEP in Amsterdam, but can you explain a little bit more why there was, you think it was so individual focused?
Yeah, thank you for your question. So I've actually only shown here the reason why they really differentiate between these regimens, but they were also asked why they wanted to use PrEP in general, and there we've seen more the societal impact, so they wanted to contribute to implementation or the openness about PrEP and HIV.
Well, this was a wonderful session. Thank you to all of our speakers. I think we learned a lot about information, access, appeal, and choices. So big hand to our last speaker and to everyone else.